Welcome to the Deep Dive, the show where we really try to get to grips with complex medical topics, giving you the essential insights, well, the things you need to be truly well informed in your practice. Today, we're focusing on a joint that, despite its small size, is just absolutely fundamental to almost every single thing our patients do daily. From intricate surgical tasks right down to simply holding a pen. We're talking, of course, about the thumb. And when its foundational joint, the one right at its very base, is compromised, the impact on daily life and indeed professional function can be profoundly debilitating. So, this deep dive is dedicated to basal thumb arthritis, also widely known, of course, as trapeziometacarpal or sometimes carpometacarpal joint arthritis of the thumb. It's a condition we encounter with, well, remarkable frequency in hand clinics all across the United Kingdom, presenting a unique set of diagnostic and treatment challenges for us as clinicians. Our mission today is to explore this condition comprehensively. We'll unpack its intricate anatomical and physiological mechanisms, delve into the various diagnostic approaches that guide our clinical decisions, examine the current evidence-based treatment paradigms, both conservative and surgical, and, crucially, shine a much-needed light on the often overlooked aspects of patient recovery and their holistic well-being. To guide us through this detailed discussion, we're incredibly fortunate to have an insightful authority in orthopedics and hand surgery joining us today.
It's a real pleasure to be here. This is an incredibly important area within hand surgery, one that impacts a significant number of our patients quite directly, often limiting their ability to work and, engage in daily life. So I'm keen to delve into the nuances of how we can best support them.
Thank you for joining us. Let's begin right at the start then. When we refer to arthritis, particularly in the context of the thumb, how do we precisely define this condition, and what are the key terms that, as medical professionals, we should be most familiar with?
Right. Well, what's essential to understand from the outset is that arthritis, at its very core, signifies irritation, or more fundamentally, the progressive destruction of a joint. This process primarily involves the wearing out of the protective articular cartilage surface, that smooth layer that normally cushions the ends of bones, allowing them to glide smoothly against each other. Now, in the thumb, the most frequent and clinically significant site for arthritis development is precisely at its base, what we refer to as the basal joint, or more technically, the thumb carpometacarpal joint, often abbreviated just to CMC joint. This joint is truly the workhorse of the thumb.
The CMC joint, right?
And when we diagnose arthritis predominantly affecting this basal joint, we're almost invariably referring to osteoarthritis. This is synonymous with what's commonly termed degenerative arthritis, or perhaps more colloquially wear and tear arthritis.
Okay, so degenerative, not inflammatory primarily.
Exactly. That distinction is crucial because it immediately informs our understanding of the underlying pathological process. It's primarily a mechanical breakdown, not an inflammatory process like, say, rheumatoid arthritis. In clinical practice, you'll encounter several interchangeable terms for this condition, and it's helpful to be familiar with them all for clear communication. We might hear it called basilar thumb OA, thumb carpal metacarpal joint OA, or CMCJ OA, thumb trapeziometacarpal joint OA, or TMCJ OA, or even saddle joint OA, given the unique shape of the joint itself.
Saddle joint, yes.
The key insight here is that regardless of the specific term used, we're almost always dealing with the same fundamental degenerative process in this really critical joint.
That distinction between degenerative and inflammatory arthritis is certainly a foundational point. Given it's essentially a wear and tear issue, let's explore the anatomy a bit more. The thumb CMC joint is often described as a universal joint. What makes its architecture so special and perhaps paradoxically so vulnerable to these degenerative changes?
It truly is a remarkable feat of natural engineering, actually. The thumb CMC joint is classified as a unique biconcave saddle joint. You can sort of imagine two saddles perfectly fitted together, allowing movement in multiple planes. It's formed by the trapezium bone of the wrist and the first metacarpal bone of the thumb. This unique architecture is specifically designed to facilitate an incredibly wide range of movements, swiveling, pivoting, and crucially, opposition, that unique human ability to bring your thumb across your palm to meet your other fingers.
Which is vital for grip.
Absolutely. These movements are indispensable for things like fine gripping, grasping, and the precise manipulation of objects, which are fundamental to nearly every daily activity, from, buttoning a shirt to performing intricate surgical maneuvers. Normally, the ends of these bones are covered by smooth articular cartilage. This cartilage acts like a lubricated, low-friction surface, enabling effortless gliding and a wide, pain-free range of motion.
Wow.
However, and this is the crux of it, this extensive mobility comes at a significant biomechanical cost. The CMC joint endures substantial stresses. Consider this. The reactive force across the CMC joint can be up to 13 times the applied pinch force.
13 times. That's astonishing.
It is. To put that into perspective, imagine the equivalent of pressing down with, well, a small weight, maybe 10, 15 kilos, on a joint that's only a few square centimeters in size, every single time you pinch something forcefully. This astonishing, repeatedly applied load over many years provides a very clear and compelling rationale for its inherent susceptibility to degenerative changes. It's hardly surprising it wears out, really.
That 13 times statistic certainly clarifies the immense stress on such a small area. It makes perfect sense then why it's so prone to wear. But beyond just the forces, what about the inherent stability of the joint? Are there specific structures designed to hold it all together? And how do their roles factor into this vulnerability and the progression of the disease?
Yes, joint stability is absolutely paramount for such a mobile joint, and it relies heavily on its sophisticated ligamentous support system. The most critical stabilizing ligaments are the anterior oblique, often referred to as the volar beak ligament, and the dorsiradial ligaments. The volar beak ligament is widely considered the primary static restraint against subluxation, meaning it's the main structure preventing the metacarpal from slipping forward, sort of volarwards and out of place from the trapezium.
Okay, the volar beak ligament.
And the dorsiradial ligament, on the other hand, is generally regarded as the strongest and thickest primary restraint against dorsal dislocation, preventing the thumb from dislocating backwards. We also have the inner metacarpal ligament, which plays a vital role in resisting radial translation or the thumb moving sideways, radially. These ligaments are truly the unsung heroes of thumb stability, working constantly to keep that saddle joint congruent, nice and lined. However, with the high forces, the repetitive motion, and sometimes the natural laxity that develops with age, or perhaps genetic predisposition, these ligaments can stretch, weaken, or even, in some cases, rupture.
Right.
If we connect this to the bigger picture, any attenuation or injury to these crucial structures immediately compromises the joint's intrinsic stability, initiating that cascade of degeneration that we talked about. Once that crucial ligamentous belt, as it were, loosens, the bones are no longer held tightly in their optimal position, setting the stage for the cartilage damage.
So, the ligaments, despite their foundational role, can indeed be a vulnerable link over time. Let's really delve into that cascade then. How does this degeneration actually progress, step by step, from a relatively stable joint to one that's causing significant pain and eventually visible deformity for the patient?
Yes, the pathophysiology of basal thumb arthritis truly outlines a sort of vicious cycle of degeneration. It often starts quite subtly and progresses relentlessly if it's unchecked. The initial domino to fall is often the weakening or even rupture of the volar oblique ligament, that critical anterior oblique ligament we just discussed. As individuals age, or sometimes due to specific microtraumas from repetitive activities, this ligament, so vital for CMC joint stability, can lose its integrity.
Okay, so ligament laxity is the starting point.
It's often the crucial turning point, yes. This ligamentous compromise leads directly to a loss of joint congruency. Put simply, the bones no longer fit together perfectly like they once did. The first metacarpal bone then begins to misalign or sublux relative to the trapezium. You could perhaps imagine a tent pole that's no longer sitting squarely on its base. The load isn't distributed evenly anymore. This misalignment initiates a rapid and destructive cycle of cartilage degradation. The cartilage, no longer subjected to perfectly distributed loads, begins to thin and erode unevenly, much like a car tire wearing out faster on one side if the alignment is off.
That makes sense.
As this protective cartilage diminishes, you get direct bone-on-bone contact during movement. This contact is precisely what causes the deep, aching pain and grinding friction that patients so often describe. Over time, this constant bone-on-bone rubbing stimulates the body to try and stabilize the joint, leading to the formation of osteophytes, bony projections along the joint margins.
Those bony spurs.
Exactly. These osteophytes are the body's sort of desperate attempt to add stability, but they often contribute to further stiffness, pain, and restricted motion, creating a painful feedback loop.
And this leads to visible changes.
Yes, clinically, this degenerative process can manifest as visible and often distressing deformities. Early on, you might observe a characteristic flexed posture of the thumb with a noticeable fullness at its base, due to the bony changes and the subluxation. In more advanced cases, this can progress to what's known as a zigzag or swan neck deformity. This involves a progressive adduction, or drawing inwards towards the palm of the first metacarpal bone, coupled with a compensatory hyperextension of the metacarpophalangeal, or MCP, joint the middle joint of the thumb.
Ah, the zigzag shape.
That classic deformity is a clear, visible sign of significant disease progression and chronic instability, making everyday tasks even more challenging for the patient.
That's a very clear step-by-step picture of how the joint deteriorates. Given that progression, who is most susceptible to developing basal thumb arthritis? Are there specific demographics, genetic predispositions, or lifestyle factors that, as clinicians, we should be particularly aware of when assessing our patients?
This is a critical area for us to understand, both for patient counseling and for early identification. Basal thumb arthritis is an incredibly common hand arthritis, indeed second only to distal interphalangeal or DIP arthritis in prevalence. The pattern we typically observe in hand osteoarthritis is that the DIP joints are most frequently affected, followed by the thumb CMC joint, then the proximal interphalangeal PP joints, and finally the metacarpophalangeal MCP joints. So thumb CMC is number 2.
DIP, then CMC, then PIP, then MCP.
Yeah.
Got it.
Precisely. Radiographic evidence is quite widespread. Studies show it's present in approximately 25% of women over 55 and a striking 40% of women over 75. However, and this is a vital clinical point, many individuals with radiographic changes may accommodate these symptoms without ever seeking medical treatment. So the true symptomatic prevalence we see in clinic is often lower than what the x-rays might suggest.
So radiographic findings don't always equal symptoms.
Exactly. That disconnect is really important. Interestingly, it's also more common in Caucasian populations compared to other ethnic groups when we look at hand osteoarthritis generally. Demographically, there's a significantly higher incidence in women compared to men, often with a female-to-male ratio as high as 6.1 being reported.
6 to 1, wow.
Yes, it's quite striking. It typically emerges after 40 or 50 years of age, with a particular predisposition in postmenopausal women. This leads directly to the strong genetic and hormonal influences at play. There seems to be a clear genetic predisposition, indicating a familial tendency. If your mother or grandmother had it, you might be at higher risk yourself. Furthermore, the decline in protective estrogen levels during menopause seems to play a significant role in increasing vulnerability.
The estrogen link again.
Indeed. Estrogen is thought to have a protective effect on cartilage and perhaps joint stability, and its reduction seems to remove this buffer, accounting for the notably higher incidence in postmenopausal women. Traumatic antecedents are also notable predisposing factors. Previous injuries or trauma to the thumb, such as Rolando or Bennett fractures, these are specific fractures involving the articular base of the metacarpal, can significantly increase risk if they heal in a malunited position, disrupting the joint's delicate mechanics.
So previous injury is a big one.
It certainly can be. Joint hypermobility is another consideration. Excessive basal joint laxity or generalized joint hypermobility, often more prevalent in younger women, could theoretically predispose individuals to premature degenerative changes due to repeated loading of subluxed joints. While this theory has been discussed, for instance in the context of conditions like Ehlers-Danlos syndrome, direct experimental evidence definitively linking generalized hypermobility directly to basal thumb osteoarthritis is still perhaps a subject of some debate in the literature. It's plausible, but not fully proven.
Okay, so hypermobility is a maybe. What about work and lifestyle?
Occupational and lifestyle contributions certainly shouldn't be overlooked. For patients engaged in manual labor, certain crafts, or even extensive use of hand tools, activities involving repetitive gripping and pinching motions place additional sustained stress on the joint. Obesity is another lifestyle factor that can exacerbate joint stress, potentially through systemic inflammation and certainly through increased mechanical load on weight-bearing joints, though its direct impact on hand joints is perhaps less clear, but still considered a factor. Lastly, we must consider associated systemic conditions. Inflammatory arthritides, such as rheumatoid arthritis, can involve the basal joint. Approximately 1/3 of affected rheumatoid arthritis patients may experience basal joint involvement. Despite all these identifiable risk factors, it's important for us to remember that the most common cause of symptomatic basal joint arthritis remains idiopathic, arising from a complex, often unseen interplay of these various elements.
That's a truly comprehensive overview of the risk factors, highlighting the multifactorial nature of this condition. Now let's turn to how patients typically present in our clinics. What are the cardinal symptoms that should immediately raise our clinical suspicion, and what kind of story does the patient usually tell us?
The patient's story is often remarkably consistent, and understanding it is, well, half the diagnosis, isn't it? The cardinal and most common presenting symptom is pain localized directly to the base of the thumb. This pain frequently radiates to the thenar eminence, that fleshy part of the palm at the base of the thumb, and sometimes even up towards the metacarpophalangeal or MCP joint, the large knuckle of the thumb.
Okay, pain at the base, radiating outwards.
Yes. And what's particularly telling is how activity-related the pain typically is. It's almost always exacerbated by activities requiring fine or forceful grip and pinch. Think about the everyday tasks that patients often complain about. Turning a key, struggling to open jars, unscrewing bottle tops, writing for extended periods, or even trying to snap their fingers. These seemingly simple actions become incredibly painful.
Those specific activities are key clues.
Absolutely. And as the condition progresses, this intermittent activity-related pain can unfortunately become constant, significantly impacting their quality of life and independence. Beyond pain, other key manifestations include noticeable swelling and tenderness directly at the base of the thumb. Patients often report an aching discomfort after prolonged use of the thumb, a feeling of fatigue in the hand, and a marked reduction in grip strength becomes evident, directly impacting their functional capabilities.
Weakness is a big complaint too, then.
Yes, weakness and pain often go hand in hand. In more advanced cases, we start to see more pronounced signs on inspection. There might be an enlarged, almost out-of-joint appearance or a distinct dorsal-radial prominence, a noticeable bump at the base of the thumb. A bony prominence or bump directly over the basal joint is also very common. Patients will also report limited thumb motion and, quite tellingly, crepitus, that gritty, crackling, or grinding sound or sensation during joint movement.
Crepitus, that crunching sound.
That's the one. It strongly implies significant cartilage erosion and bone-on-bone friction. All of these symptoms, of course, converge to cause significant functional impairment, making it difficult for patients to perform daily tasks, impacting fine motor skills, and sometimes leading to an inability to effectively abduct the thumb, meaning they struggle to move it away from the palm, limiting their ability to grasp larger objects.
That paints a very clear clinical picture for us. Once we have that crucial patient history, what are the next crucial steps in the clinical examination to confirm the diagnosis and uncover the underlying signs that will inform our management?
Right, a comprehensive clinical examination is where we truly bring the history to life. It's vital to begin with a detailed history, specifically inquiring not just about symptom patterns, but any prior hand or thumb injuries, and precisely which activities aggravate their condition. What's often overlooked but incredibly important is the high prevalence of concomitant conditions that frequently accompany basal thumb arthritis. We know that up to 50% of patients with basal thumb arthritis can also have carpal tunnel syndrome.
50%, wow.
Yes, so we must ask about tingling, numbness, or night pain. We also frequently encounter scaphotrapezial arthrosis, trigger digits, metacarpophalangeal (MCP) hyperextension, and tenosynovitis of the wrist, like de Crevaine's. Therefore, it's crucial to proactively inquire about and assess for these conditions during our comprehensive examination to ensure we develop a truly holistic and tailored management plan.
So check for carpal tunnel, de Quervain's, trigger finger.
Exactly. Missing these coexisting issues could lead to suboptimal outcomes for our patients. During inspection, especially in more advanced cases, you'll often observe visible signs such as bony swelling or that dorsal-radial prominence of the thumb metacarpal base. Palpation is key. You'll find characteristic localized tenderness directly over the thumb carpometacarpal (CMC) joint. And as we discussed earlier, the presence of crepitus during examination, that gritty or crackling sensation, strongly implies significant erosion of the articular cartilage.
In the specific tests.
We then move to provocative maneuvers, which are invaluable for eliciting specific responses. The CMC grind test is a classic and highly informative. This is performed by applying axial compression through the thumb and simultaneously rotating or circumducting the thumb metacarpal base.
Grinding the joint, essentially.
In effect, yes. A positive test, indicated by the reproduction of pain or distinct crunching sensation, is highly suggestive of underlying degenerative disease and cartilage wear. Another useful test is the distraction or torque test, where you apply gentle axial traction while rotating the thumb metacarpal base. A positive result here often indicates synovitis, which is inflammation of the joint lining, and is more typically associated with milder disease stages where inflammation rather than just bone-on-bone rubbing might be a prominent feature.
So grind test for wear, distraction test for synovitis.
Broadly speaking, yes, though for our medical audience, it's worth noting that while valuable, these provocative tests are perhaps more commonly utilized and refined in specialist hand surgery settings, where a precise diagnosis is paramount for surgical planning.
Okay, that makes sense. So we've gathered the patient history, performed a thorough clinical exam, including looking for those associated conditions, and now we need to see what's happening beneath the surface to confirm our suspicions and precisely stage the disease. What role do imaging studies play, and how do we use them to categorize the severity of the condition?
Right. Imaging, particularly radiographs, are absolutely fundamental. They are essential not just for confirming our clinical diagnosis, but crucially for assessing the severity of the disease and ruling out other osseous abnormalities that might mimic the condition. For standard views, we always obtain AP and lateral projections of the hand. However, the Roberts view is particularly important and really a cornerstone for diagnosing basal thumb arthritis.
The Roberts view, okay. How is that done?
It's a postero-anterior view of both thumb trapeziometacarpal joints, taken with the thumb flat on the cassette and hyperpronated. This specific positioning provides the best visualization of the joint surfaces and any abnormal changes. A lateral wrist view can also be immensely useful to assess overall alignment and any coexisting ligament attenuation in the wider wrist complex.
And what are we looking for on these x-rays?
We look for key findings that signify degenerative changes. Firstly, joint space narrowing, which directly indicates cartilage loss. Secondly, subchondral sclerosis, which is a hardening and increased density of the bone directly beneath the cartilage, indicating increased stress. And thirdly, the formation of osteophytes, those extra bony projections along the joint margins, which are the body's attempt at stabilization.
Narrowing, sclerosis, osteophytes, the classic OA signs.
Precisely. To systematically assess the disease severity and guide our treatment decisions, we commonly use the Eaton and Glickle classification system. This widely accepted system stages pathological changes in the basal joint based purely on radiographic appearance, and it's crucial for both preoperative planning and for effectively educating our patients about their condition.
Can you briefly outline those stages for us?
Certainly. Stage 1. Characterized by normal trapeziometacarpal joint contours, but perhaps some widening, maybe with less than one-third joint subluxation seen on stress views. This is considered a pre-arthritis state, often with instability but minimal actual cartilage damage yet. Stage 2, here we see slight TM joint narrowing with sclerosis and osteophytes, or maybe loose bodies less than 2 millimeters. Instability may also be apparent on stress views, with equal to or greater than one-third joint subluxation. This indicates early but definite degenerative changes. Stage 3 shows marked TM joint narrowing, prominent subchondral sclerosis, and osteophytes or loose bodies greater than 2 millimeters. Significant subluxation equal to or greater than one-third typically persists. This is clear advanced arthritis of the CMC joint itself. Stage 4 represents the most advanced disease affecting not only the TM joint but also the scaphotrapezial (STT) joint, the joint between the scaphoid and trapezium bones. This is termed pantrapezial arthritis, involving the entire trapezial complex.
Pantrapezial. So stage 4 involves the neighboring joint too.
Exactly. While X-rays are generally the primary imaging modality, CT scans may occasionally be used for a more detailed view of bone structures, especially for complex surgical planning, where precise bone anatomy is required. However, it's important to remember that magnetic resonance imaging, MRI, tomography, or ultrasonography, are generally not indicated for routine evaluation of basal joint disease. X-rays usually provide sufficient information for diagnosis and staging.
Good to know MRI isn't typically needed here.
Yes. And a crucial clinical point to reiterate, one that often surprises patients, is that there is frequently a poor correlation between the radiographic severity of degenerative disease and the patient's clinical symptomatology.
Yes, you mentioned this disconnect.
Indeed. You might find patients with minimal joint space narrowing experiencing disabling pain, while conversely, some asymptomatic patients may incidentally present with stage 5E disease on radiographs. It really underscores that we treat the patient, not just the picture.
That's a vital reminder that the imaging doesn't always tell the whole story when it comes to patient experience, and our clinical assessment remains paramount. Before we delve into treatment strategies, what other conditions might present similarly to basal thumb arthritis, potentially confusing the diagnosis, and how do we accurately differentiate them?
Distinguishing basal thumb arthritis from conditions that mimic its symptoms is absolutely essential for accurate diagnosis and, critically, for ensuring we provide the appropriate and effective management. It really prompts the question, what else could this be that presents with similar thumb and wrist pain?
The differential diagnosis.
Precisely. One condition to consider is C6 radiculopathy. This is characterized by pain radiating from the neck, with paresthesias or numbness and tingling primarily affecting the thumb and index finger. This suggests a nerve root issue in the cervical spine rather than a primary joint problem in the hand. We differentiate this through neck examination, specific neurological tests, and potentially imaging of the cervical spine.
So always consider the neck.
Always. Diacrovane's tenosynovitis is another common mimic. This is an inflammation of the tendons in the first dorsal compartment on the thumb side of the wrist. It's distinguished by a positive Finkelstein's test, where pain is reproduced when the thumb is flexed into the palm, the fingers are wrapped over it, and the wrist is then sharply deviated towards the ulna. This specifically irritates the affected tendons, differentiating it from CMC joint pain.
Finkelstein's for decurvanes.
Spot on. Scaphotrapezial SDT arthritis causes pain and tenderness typically localized, just proximal or closer to the wrist, compared to the TMC joint itself. Because of the close anatomical relationship, it can be easily confused. Diagnostic injections precisely into the SDT joint or specific radiographic views focusing on this area may be needed to differentiate it.
So location of tenderness is key there.
It helps, yes. We also must actively look for conditions like scaphoid non-union advanced collapse, SNASD's wrist, and radioscaphoid arthritis. These are chronic conditions stemming from previous scaphoid fractures or long-term degenerative changes in the wrist. Both are usually evident on standard wrist radiographs, and their distinct radiographic patterns help us differentiate them, as they require very different management strategies than basal thumb arthritis.
Okay, check the wrist x-rays carefully too.
And finally, given its high co-occurrence with basal thumb arthritis, as we mentioned, up to 50% of patients, it's absolutely crucial to assess for signs of carpal tunnel syndrome. This is compression of the median nerve at the wrist. Patients might report numbness, tingling, or pain in the thumb, index, middle, and half of the ring finger, particularly symptoms that wake them at night. If suspected, nerve conduction studies may be required to confirm this diagnosis.
Right, never forget the carpal tunnel.
The careful differentiation of all these conditions ensures we're treating the correct pathology, or, as is often the case, multiple pathologies simultaneously, leading to much more effective patient care.
With a confirmed diagnosis and a clear understanding of potential mimics, let's explore the treatment landscape. What's the initial approach we should always consider? And how far can conservative management realistically take a patient before we consider surgical options?
Conservative management truly forms the indispensable foundation of care for basal thumb arthritis. It's the absolute mainstay of initial treatment, even sometimes in later stages of the disease, particularly for patients presenting with mild to moderate symptoms. It's important to convey to our patients that a significant number of them actually achieve satisfactory long-term outcomes and excellent pain control with these non-surgical approaches alone. This can be very reassuring for them to hear.
So always start conservative.
Always. Activity modification is paramount. We advise patients on avoiding activities that exacerbate their pain, such as less forceful pinching or suggesting they alternate hand use to reduce strain. Simple but effective changes, like using larger diameter writing instruments, ergonomic tools, or adaptive kitchen aids like jar openers, can significantly reduce the cumulative stress on the joint. This empowers patients to manage their symptoms actively.
Simple changes can make a big difference.
They really can. For pharmacological interventions, over-the-counter analgesics and non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, or naproxen are often the first line to manage pain and reduce inflammation and swelling. When these aren't sufficient for mild to moderate disease, intra-articular corticosteroid injections directly into the carpometacarpal joint are a common second-line treatment. These typically provide pain relief for several months, often between 3 to 6 months, maybe longer for some.
Steroid injections are quite effective then.
They can be very effective for symptom control, yes. However, their effect can diminish with repeated injections, and they carry a theoretical, albeit small, risk of weakening capsular support or even compromising articular cartilage over the very long term. So it's generally advised to limit their frequency, perhaps to 2 or 3 injections per year at most into one joint.
Limit the injections. What about other types? Hyaluronic acid.
Good question. Current evidence does not support the routine use of hyaluronic acid injections for basal thumb arthritis. Studies have shown no significant difference in pain relief or functional improvement compared to placebo or corticosteroids. So that's an important distinction to make for patients who may have heard about them for, say, knee arthritis.
Okay, no hyaluronic acid. What about glucosamine and chondroitin?
The area of chondroprotective agents like glucosamine and chondroitin sulfate remains quite controversial. While some patients may wish to try them, and there's probably little harm, it's crucial to caution them about the distinct lack of robust clinical evidence for their efficacy in repairing cartilage or decelerating the degenerative process in this specific joint. We must manage patient expectations carefully here.
So limited evidence for those supplements.
Very limited, yes. Immobilization and support are also key components. Supportive splints are highly beneficial in limiting thumb movement and allowing the joint to rest and inflammation to settle. The most effective is often a well-fitted, custom-made thumb spica splint, which specifically immobilizes the basal joint while allowing other finger movement.
A custom splint is best.
Often, yes, for comfort and precise immobilization. Initially, continuous wear for maybe 3 to 4 weeks is recommended, gradually transitioning to intermittent use, perhaps just for symptomatic periods or when anticipating heavy loads like gardening or gripping tools.
And finally, exercise and physio.
Absolutely vital for long-term success. We advocate for structured physical therapy program, often led by a specialist hand therapist, to enhance function and alleviate pain. Specific exercise regimens include the Hungar intrinsic and extrinsic muscle strengthening exercises to build dynamic stability around the joint, thumb IP flexion, bending the thumb MP flexion, bending the thumb at the base towards the palm and thumb opposition exercises to improve grasping and pinching capabilities. Manual therapy techniques, like gentle joint mobilizations to restore movement and soft tissue manipulation to break down scar tissue, can be integrated. Therapeutic taping can also support the joint for daily activities. We also recommend assistive devices and general joint protection techniques to reduce strain.
Heat and cold.
Temperature therapy, using heat to decrease pain and enhance motion, or cold packs for flare-ups, can provide symptomatic relief for some people, though evidence for their long-term efficacy in modifying disease progression is mixed. The key insight for conservative management is that it's about empowering the patient to manage their symptoms and protect their joint, often achieving significant improvement without ever needing surgery.
That sounds like a robust and multifaceted first line of defense. But as you alluded to, what happens when conservative measures simply aren't enough? When pain and disability persist despite our best efforts? When do we start considering surgical interventions, and what are the overarching principles guiding those complex decisions?
That's precisely when we transition our focus towards surgical options. The clear indications for surgery are persistent pain and functional disability that are not adequately controlled by comprehensive conservative treatments, particularly in a compliant patient who has genuinely given conservative measures a fair trial, perhaps over 3 to 6 months. The staging of the disease, using that Eaton and Glickle classification we discussed, becomes absolutely crucial at this point, as it heavily guides the selection of the most appropriate surgical procedure for that individual patient. A stage I patient will likely be considered for very different interventions than a stage 5 patient.
Staging really directs the surgical choice.
It does. In terms of general surgical principles, most operations for basal thumb arthritis can typically be performed on an outpatient basis, meaning the patient goes home the same day. This is usually done under general anesthesia or regional anesthesia, an arm block which can be beneficial for patient recovery. These procedures are generally quite efficient, often taking less than an hour of operative time, sometimes even quicker. The primary goal across all these surgical approaches is fundamentally straightforward: to prevent that painful bone-on-bone rubbing that is causing the symptoms and functional limitation. It's about restoring a pain-free articulation or removing the source of the pain altogether.
Remove the rubbing, remove the pain.
Essentially, yes. The decision regarding the specific surgical option is always a collaborative one, a shared decision-making process between the surgeon and the patient. We carefully consider the patient's age, their functional demands. Do they need fine dexterity or powerful grip? Their expectations for recovery and future function, and of course, the specific preoperative radiographic findings. It's a truly tailored approach because one size certainly does not fit all in hand surgery, especially not here.
Given that wide range of options and the tailored approach, let's take a deep dive into each of the specific surgical procedures, starting with first metacarpal osteotomy. How does this procedure work, and for what type of patient is it most suitable?
Certainly. A first metacarpal osteotomy involves cutting and then precisely realigning the metacarpal bone, typically through what we call a closing wedge dorsal extension osteotomy. The principle here is quite clever, actually. It aims to essentially redirect the forces acting across the joint to a more dorsal, or back of the hand portion of the first CMC joint surface. This less involved, often healthier, part of the joint that then takes on more of the load, thereby reducing stress and pain in the main arthritic damaged area. It's a bit like shifting the weight onto a stronger part of a foundation.
Redirecting the force. Clever. And who is it for?
This procedure is primarily indicated for patients in the early stages of disease, stage IDPI, where the joint destruction isn't too advanced and there's still a reasonably healthy portion of cartilage to offload onto. However, it's not suitable for everyone. Contraindications include patients with significant hypermobility of the joint, a fixed subluxation of the CMC joint that cannot be easily reduced, or pre-existing MCP hyperextension greater than about 10 degrees, as these conditions might not benefit or could potentially even be exacerbated by the osteotomy.
So early stage, stable joint, no hyperextension.
That's the ideal profile. Despite these limitations, it has gained popularity, particularly for younger patients with early disease. And reported symptom improvement rates can be quite high, maybe as high as 93% at 7 years post-procedure in some series. It's a good option for specific, carefully selected early-stage cases where preserving length and some motion is really key.
That's quite a high success rate for the right patient profile. What about trapeziectomy, which I understand is perhaps the most commonly performed procedure, and how has the approach to it evolved over time, particularly regarding managing the space left by the removed bone?
Yes, trapeziectomy is indeed the most commonly performed surgical option for basal thumb arthritis globally, and it represents a real paradigm shift in managing this condition compared to, say, fusion. It fundamentally involves the complete removal of the trapezium bone, the wrist bone that forms one surface of the arthritic joint. The core idea is simple and effective. If the pain comes from the bone-on-bone rubbing of the trapezium against the metacarpal, remove the trapezium.
Just take out the problem bone.
Exactly. Historically, this procedure often involved quite complex ligament reconstructions, or filling the created space with a rolled-up tendon, a technique known widely as ligament reconstruction and tendon interposition, LRTI. The rationale was to prevent the thumb metacarpal from migrating proximally, or sort of sinking down, into the void left by the excised trapezium and potentially hitting the scaphoid.
The LRTI technique? I've heard of that.
Yes, it was very popular for a long time. However, contemporary practice has seen a fascinating evolution. Some modern practices, supported by good evidence, suggest that simply excising the trapezium and meticulously repairing the joint capsule, allowing the space to fill naturally with scar tissue, a process known as hematoma arthroplasty, or fibrous interposition, yields comparable functional results without the added complexity, potential morbidity, and operating time of extensive soft tissue procedures like tendon harvesting.
So maybe the complex reconstruction isn't always necessary.
That's what a lot of evidence suggests now. The body's natural healing can be incredibly effective in creating a stable pseudoarthrosis, a fibrous joint, that functions remarkably well. Now, when suspension is performed, perhaps in younger patients or those with higher demands where maintaining length is critical, various tendons can be used to support the thumb metacarpal. The flexor carpi radialis, FCR tendon, is the most common choice for suspending the metacarpal due to its location and strength. Other options include the extensor carpi radialis longus, ECRL, or using a slip of the abductor pollicis longus, APL. More recently, newer techniques like suture suspension, for example, using a portion of the APL tendon to suspend to the FCR tendon with strong sutures, and the mini tightrope system are gaining traction. The mini tightrope in particular is a procedure I personally prefer for many cases as it effectively restores CMC joint stability using an internal brace ligament augmentation.
A mini tightrope, like the ones used elsewhere in orthopedics.
Precisely a similar concept adapted for the thumb CMC joint. It provides a robust and predictable solution for maintaining the thumb's length and stability post-trapeziectomy, using a strong synthetic suture device rather than harvesting more tendon, which simplifies the procedure.
Interesting. And who's trapeziectomy suitable for? Which stages?
Trapeziectomy is highly versatile, suitable for a wide range of disease stages, from stage I, particularly if symptomatic and failing conservative care, all the way through to stage 4. It's particularly indicated when there is concomitant scaphotrapezoarthrosis, meaning arthritis also affecting the joint between the scaphoid and trapezium bones, which is present in a significant number of cases, perhaps up to 62%, especially in stage 4 disease. In such instances, excision of the proximal third of the trapezoid bone might also be considered to address the broader degeneration if the STT joint is also severely affected.
So it covers most stages, even the advanced ones. What are the potential downsides or complications?
As with any surgery, there are potential complications. These can include injury to the radial artery, though the risk is generally lower at the TMC joint level compared to, say, more proximal wrist surgery, and injury to the superficial radial nerve, which runs nearby. Nerve injury can lead to areas of sensory deficits or occasionally a persistent painful neuroma. A notable specific complication occurring in perhaps around 5% of cases is symptomatic proximal migration of the thumb metacarpal. This is where the metacarpal drops down into the space created by the excised trapezium and potentially impinges on the scaphoid. If this becomes symptomatic, causing pain or weakness, it can be quite difficult to stabilize and may necessitate further procedures, such as a sling-type reconstruction or even fusion to the index metacarpal in severe cases. This is particularly concerning in younger, more active individuals, where maintaining long-term thumb length and function is paramount.
So that thumb shortening or collapse is the main specific risk.
It's certainly one of the key procedure-specific risks we counsel patients about. Despite these potential issues, the outcomes of trapeziectomy are generally very positive. It typically provides significant pain relief and allows for continued, useful motion of the thumb. While some degree of proximal metacarpal subsidence, maybe around 25% on average seen on radiographs, can occur postoperatively, this typically does not impact the functional outcome significantly. Patients often experience improved grip and pinch strengths compared to their preoperative state, leading to high satisfaction rates overall.
It's fascinating how the surgical approach continues to evolve for trapeziectomy. What about joint fusion or arthrodesis? When is that considered, and what are the distinct trade-offs for the patient?
CMC arthrodesis, or joint fusion, involves permanently fusing the bones of the joint, specifically the trapezium and the base of the thumb metacarpal, together to create a solid, immobile unit. The goal here is simple and direct. By eliminating all movement at that specific joint, we eliminate the pain originating from it. The joint is typically fused in a functional position, commonly around 35 degrees of radial abduction, 30 degrees of palmar abduction, and maybe 15 degrees of pronation, to ensure optimal functionality for grasping and pinching activities, despite the complete stiffness at the fused joint.
Fused in a useful position. Who is this best for?
This procedure is primarily recommended for physically high-demand patients, particularly younger males, typically maybe under 50 years of age, where preserving maximal grip strength and maintaining the absolute stability of the thumb column are prioritized over range of motion. Think of a carpenter, a builder, or perhaps a weightlifter, individuals whose livelihoods or activities depend on a powerful, stable pinch and grip. It's generally contraindicated if there's significant coexisting scaphotrapezoidal (STT) arthritis, because fusing the CMC joint would simply transfer the painful stresses to the adjacent, already arthritic STT joint, likely leading to persistent pain just proximal to the fusion site.
So check the STT joint carefully before considering fusion.
Absolutely critical. The outcomes are generally excellent in terms of providing profound pain relief, unwavering stability, and excellent length preservation of the thumb column. However, the obvious and significant trade-off is a drastically decreased range of motion at the base of the thumb. For example, patients will find it impossible to lay their thumb flat against a table, which requires CMC motion. There's also a non-union rate, meaning the bone ends fail to join solidly, of around 12%, maybe slightly higher in some series. Despite the stiffness and the risk of non-union, most patients who are carefully selected for this procedure find the pain-free and strong thumb highly satisfactory, especially those whose professional or recreational activities demand that powerful grip and absolute stability. The core insight here is that fusion sacrifices motion for guaranteed stability and strength.
That's a clear case of prioritizing strength over mobility for specific patient profiles. What about joint replacement or prosthetic arthroplasty? Is that a growing trend for the thumb CMC joint, perhaps similar to hip or knee replacements?
CMC prosthetic arthroplasty, or joint replacement, is indeed a concept that has gained some traction, particularly in parts of Europe, although it's still relatively newer as a primary option here in the UK compared to trapeziectomy or fusion. This procedure involves removing the arthritic ends of the bones, the trapezium and the metacarpal base, and inserting a new artificial joint, often described as similar in principle to a mini hip replacement. Historically, silicone implants were quite widely used in this context, though newer metal-on-polyethylene or pyrocarbon designs exist now too.
A mini thumb replacement sounds appealing. Is it recommended?
Well, while it theoretically offers the benefit of maintaining motion and potentially providing a stronger thumb compared to simple trapeziectomy and can sometimes yield good results, it is currently generally not recommended as a primary first-line surgical option in the UK for most patients.
Why the caution?
The reason for this caution lies primarily in the specific risks and the relatively higher complication rates associated with implant use in this demanding joint. These include the potential for implant fracture or, more commonly, loosening over time. Remember those 13x forces. There's also the risk of subluxation or dislocation of the implant itself and the possibility of particle wear disease like silicone synovitis with older implants, which is an inflammatory reaction to debris that can cause significant problems and require revision surgery.
So implant longevity and complications are the main concerns.
Precisely. Furthermore, this procedure is generally not suitable for patients with the most severe stage 4 arthritis, as their joint may be too damaged or the surrounding bone quality insufficient to adequately support an implant long term. This makes it a less versatile option compared to trapeziectomy for advanced cases. The real challenge here is finding an implant that can reliably withstand the immense forces acting across the thumb CMC joint without loosening, wearing out, or failing over the patient's lifetime, particularly in younger active individuals. The long-term data just isn't as robust as for trapeziectomy yet.
It sounds like while promising in theory, it comes with its own distinct set of challenges, particularly long-term ones. What about denervation, the procedure that involves selectively cutting nerves to interrupt pain signals? That seems like a very different approach entirely.
Indeed, CMC denervation is a distinct and perhaps often underappreciated approach that focuses purely on pain modulation rather than joint reconstruction or removal. This procedure involves selectively identifying and cutting small sensory nerve branches that transmit pain signals directly from the arthritic CMC joint. It can be performed through 1 or 2 small incisions, precisely targeting nerves such as the fanar cutaneous branch of the median nerve, the palmar cutaneous branch of the median nerve, the superficial branch of the radial nerve via the dorsal articular nerve of the first interosseous space, and sometimes the branch of Cuvillier from the lateral antebrachial cutaneous nerve. The precise anatomical knowledge and mapping of these nerves allows for targeted pain relief while preserving other motor and critical sensory functions of the hand.
Just cutting the pain wires, essentially. Who is it for?
This technique is potentially applicable across all stages of the disease, from stage I right through to stage 4, although its specific indications are still evolving as we gather more long-term outcome data. The primary specific complication is potential injury to a sensory branch of the radial nerve, which can lead to areas of numbness on the back of the thumb, or, less commonly, a painful neuroma if a nerve ending gets irritated. Careful surgical technique minimizes this risk, of course. It's also important to note that, as with any pain-modulating procedure, not all patients achieve significant or complete improvement, and some may still experience some residual discomfort.
But for those it works for.
For those who do respond well, outcomes often include improved hand function, enhanced grip strength, likely due to pain reduction, and significant pain relief. In terms of pain control, results can be comparable to trapeziectomy and CMC arthrodesis in some studies, but with the distinct advantage of preserving the patient's natural range of motion compared to fusion. This makes it an attractive option for certain patients who prioritize motion, perhaps wish to avoid more extensive joint reconstruction, or maybe aren't suitable candidates for other procedures. The key insight, as you said, is that it targets the symptom of pain directly, rather than the underlying degenerative joint itself.
And finally, a minimally invasive option, arthroscopic debridement. When is that indicated, and what does it entail?
CMC arthroscopic debridement is indeed a minimally invasive surgical approach. It involves using an arthroscope, a small camera, about 2–3 millimeters wide, inserted through tiny incisions or portals, to visualize the inside of the joint directly. The surgeon can then debride or clean out any damaged tissue such as inflamed synovium, the joint lining, or loose cartilage fragments floating in the joint. It may sometimes be combined with thermal shrinkage of lax capsule or ligaments, or even fat grafting, where a small amount of the patient's own fat is harvested and injected into the joint space to potentially provide some cushioning and support, perhaps aiding in lubrication and reducing friction.
Keyhole surgery for the thumb base. Who's suitable?
This procedure is primarily indicated for patients in the early stages of the disease, typically stage 1 or perhaps early stage 2, where the cartilage damage is still relatively contained and potentially reversible, and significant bone-on-bone changes or large osteophytes have not yet occurred. It's generally less effective once the joint has severely collapsed or developed extensive bony spurs.
So for early, primarily inflammatory or unstable cases.
That's generally the target group, yes. The technique typically utilizes specific portals, such as the dorsal 1R portal, which is just radial to the abductor pollicis longus, APL tendon, and the dorsal 1U portal, which is ulnar to the extensor pollicis brevis, EPB tendon, lying between the extensor pollicis longus, EPL, and EPB tendons. These precise small porters allow surgeons to access the joint with minimal tissue disruption, which can lead to faster initial recovery times compared to more open procedures. The core idea is early intervention with minimal invasiveness for carefully selected patients.
That's a truly comprehensive look at the various surgical pathways available, each with its specific indications and considerations. Now, once a patient undergoes treatment, particularly surgery, what does the rehabilitation and recovery journey look like? And what can we tell them to expect in terms of timelines and return to function?
The journey to regain function post-treatment, especially after surgery, is a structured and really vital process that we must prepare our patients for thoroughly. In the immediate postoperative period, one of the great benefits, as we mentioned, is that patients are typically able to go home on the same day as the operation. It's usually day case surgery. Simple oral analgesia, like paracetamol, and perhaps some short-term codeine or NSAIDs if appropriate, is usually sufficient for postoperative pain control. It's crucial for patients to elevate the hand as much as possible for the first 5 days or so to minimize swelling, which significantly aids in comfort and healing. Gentle bending and straightening of the fingers should commence from day 1 to prevent stiffness in the digits not directly involved in the thumb surgery. Keep everything else moving.
Elevation and finger movement right away. Then the cast.
For the immobilization phase, the initial bulky plaster of Paris slab applied in theater is generally removed within the first week, usually at their first post-op clinic visit. At this point, the wound is cleaned and redressed, and a custom-made thermoplastic therapy splint, or sometimes a lighter fiberglass cast, is applied. This splint or cast is typically worn for approximately 6 to 8 weeks, though the exact duration depends heavily on the specific procedure performed. Each surgical technique has different requirements for initial stability and healing time. A fusion, for instance, will require longer, more rigid immobilization than a simple trapeziectomy.
6 to 8 weeks in a splint or cast, depending on the op, then therapy.
Absolutely. A comprehensive rehabilitation program, ideally involving a dedicated specialist hand therapist, is essential for optimal outcomes. This therapy focuses initially on regaining mobility, then progressively restoring strength, and ultimately improving overall hand function and dexterity. While some discomfort may be experienced during the initial stages of rehabilitation, as tissues heal, stretch, and strengthen, this usually lessens considerably over time. It's important to manage patient expectations here. The road to full recovery is gradual, not instantaneous.
How gradual? What are the typical timelines?
Patients usually notice that the sharp, constant arthritic pain they had before surgery has resolved within about 8 weeks, once the initial post-op soreness settles. However, significant improvements in strength, endurance, and overall comfort continue for several months after that. Full recovery, in terms of getting back maximal strength and function, often takes up to a year. We even see some patients reporting continued subtle enhancements in strength and comfort for years after the procedure, which is a fascinating aspect of the body's adaptation and neuroplasticity. But realistically, initial functional recovery typically spans around 3 months, allowing a return to most light daily activities.
3 months for light activities, up to a year for full recovery. What about practical things like driving and work?
Good points. For the return to activities of daily living, wounds should obviously be kept covered and dry for the first 10 days to 2 weeks until they have fully healed. The splint or cast must also be kept dry throughout its use and is gradually weaned off under the supervision of the hand therapist, often with specific exercises being introduced as the immobilization decreases. Regarding driving, it's generally advisable to delay return until full control of the steering wheel and gear stick is achieved, and crucially, the patient feels safe and confident to react appropriately in an emergency situation. This typically might be between 8 and 12 weeks post-surgery, but individual variations certainly exist based on the surgery type, the patient's recovery, and the type of vehicle.
8 to 12 weeks for driving, potentially. And work.
For return to work, especially involving heavy manual labor, it should generally be avoided for approximately 8 weeks at minimum, sometimes longer depending on the procedure and the job demands. Specific advice should always be sought from the surgeon based on the individual's specific role and the precise physical demands of their job. A phased return is often helpful. The overall prognosis for basal joint arthritis after appropriate treatment is very positive. It's considered a very treatable condition with high satisfaction rates, often exceeding 85–90% of patients reporting positive outcomes after treatment, particularly regarding pain relief. Crucially, patients who do not achieve adequate relief with non-surgical treatment very often have a good or excellent result following surgery, with strength potentially exceeding preoperative levels within a year. That's a truly encouraging prospect for those suffering significant disability.
It's reassuring to hear such high satisfaction rates and a clear, albeit gradual, recovery path. However, no surgical procedure is entirely without its risks. What are the potential complications, both general surgical risks and those specific to thumb surgery, that we as clinicians should be carefully aware of and discuss thoroughly with our patients?
That's a critical aspect of our preoperative patient counseling, ensuring fully informed consent. First, we always acknowledge the universal risks associated with any surgical procedure. These include general complications related to anesthesia, which are always meticulously assessed preoperatively by the anesthetic team, general nerve injury, which can theoretically occur anywhere near the surgical field despite careful technique, and the risk of infection at the surgical site, which is usually low, around 1%, but always a possibility. These are standard considerations for any operation we undertake.
The standard surgical risks. What about thumb-specific ones?
Yes, there are specific complications more unique to thumb-based surgery. One is the failure to completely resolve symptoms. While relatively rare after appropriate surgery, this can occur. Sometimes it's due to pre-existing or subsequently developing arthritis in adjacent joints, for example, the STT joint, or even wrist arthritis that were not the primary target of the surgery but become symptomatic later. If this occurs and is problematic, it may necessitate further investigation or even intervention. Residual weakness is also a possibility. The thumb may initially feel weaker on the operated side, particularly after trapeziectomy where the trapezium's buttress effect is removed. While it typically improves significantly with time and dedicated rehabilitation, it may never fully return to its absolute original pre-arthritis strength, although function usually improves dramatically due to pain relief. We must set realistic expectations about strength return.
Okay, incomplete relief and some weakness are possible. What about the migration issue after trapeziectomy?
Yes, a specific concern following trapeziectomy, occurring symptomatically in perhaps around 5% of cases, is proximal migration of the thumb metacarpal. As we discussed, this is where the thumb metacarpal, no longer supported by the trapezium, drops down into the space left by the removed bone and can potentially impinge on the scaphoid or distal radius. If this migration becomes symptomatic, causing significant pain, instability, or weakness, it can be quite challenging to manage and may require further procedures, such as a sling-type reconstruction using a tendon, or in more severe or refractory cases, even fusion to the index metacarpal to provide rigid support. This particular complication is a major concern, especially in younger, high-demand individuals where maintaining long-term stability and function is paramount.
That sounds like a difficult complication to fix.
It can be. For cases of CMCJ fusion arthrodesis, there's the risk of non-union, where the bone ends fail to join together solidly. This occurs in about 5–10% of cases, maybe higher in smokers or those with comorbidities. If this non-union remains painless and stable, it can sometimes be accepted and left alone. But if it becomes symptomatic and painful, revision surgery, such as repeating the operation perhaps with a bone graft to promote healing, or sometimes converting the failed fusion to a trapeziectomy, may be required.
Non-union after fusion. What about implants?
When an implant is used in CMC prosthetic arthroplasty, there's a known risk of dislocation of the implant itself, also perhaps in the 5–10% range, depending on the implant type and technique. If an implant dislocates repeatedly or cannot be reduced, it may necessitate its removal and subsequent conversion to an alternative surgical approach, like trapeziectomy, to manage the resulting joint space and symptoms. Loosening and wear, as mentioned earlier, are the other major long-term concerns with implants.
Dislocation and loosening with implants. Anything else?
Finally, we must consider MCP hyperextension deformity, which can develop or worsen after CMC surgery. This is where the middle joint of the thumb hyperextends excessively, often as a compensatory mechanism for lost CMC motion or due to inherent laxity. Its management depends on the degree of hyperextension and whether it's causing functional problems. If it's mild, less than 10 degrees, typically no specific surgical intervention is needed. For 10 to 20 degrees, percutaneous pinning of the MCP joint and slight flashing for about 4 weeks during the initial post-op period may be performed, potentially combined with an extensor pollicis brevis, EPB, pendant transfer later to reinforce the joint dynamically. If the hyperextension is more significant, between 20 and 40 degrees, of volar capsulodesis, tightening the joint capsule on the palm side, or sesamoidesis, using the small sesamoid bones for stability, might be required. And for severe cases greater than 40 degrees of hyperextension, an MCP joint fusion may become necessary to permanently stabilize the thumb in a functional position, creating a stiff but stable and pain-free joint.
That's a lot to consider beyond the immediate surgical site, truly underscoring the complexities and the potential long-term journey in hand surgery. Beyond the physical and surgical aspects we've meticulously discussed, how does living with basal thumb arthritis profoundly impact a patient's emotional and psychological well-being? This is an area that, unfortunately, can sometimes be overlooked in a purely physical treatment model, isn't it?
It is indeed an often overlooked yet profoundly important aspect that we as clinicians must never forget. Living with chronic pain, particularly in the hands which are so integral to our interaction with the world, extends far beyond the physical limitations it imposes. It can significantly influence a patient's entire emotional and psychological well-being. What's truly fascinating and often distressing to witness clinically is the deep connection between chronic pain, regardless of its source, and mental health. This isn't simply a secondary reaction, it's often an interwoven reality for the patient.
The mind-body link.
Precisely. Patients often experience a wide spectrum of challenging emotions. Frustration is incredibly common, stemming from the sheer inability to perform seemingly simple, everyday tasks independently. Imagine the constant struggle to turn a key, open a jar, button a shirt, use cutlery, or even just hold a grandchild's hand without significant pain. This daily struggle can easily lead to deeper feelings of sadness, and in some cases, it can contribute to clinical depression and anxiety. A pervasive sense of isolation can also develop, especially if hobbies or social activities are curtailed.
That loss of independence must be incredibly hard.
It is. When someone can no longer engage in hobbies they once loved, or perhaps perform their professional duties effectively, it inevitably diminishes their quality of life significantly. This can lead to feelings of helplessness, guilt about their perceived limitations, or even jealousy when observing others perform these actions effortlessly. I've had patients tell me how utterly disheartening it is to watch their spouse easily open a bottle they've struggled with for minutes. It chips away at their self-esteem.
And does this emotional state affect the physical symptoms?
Absolutely. The mind-body interconnection is particularly strong in chronic pain conditions. Stress, anxiety, and low mood can demonstrably amplify pain perception. It creates a challenging feedback loop where the emotional distress exacerbates physical symptoms, which in turn increases the emotional distress, making recovery much more difficult. Untreated mental health conditions such as anxiety and depression are clearly linked in research to heightened pain perception, slower rehabilitation progress, and ultimately poorer functional outcomes in patients with thumb arthritis and indeed many other chronic conditions.
So addressing the mental health aspect is crucial for physical recovery, too.
It really is. This raises an important question for us. If we only treat the physical joint, the cartilage, the bone, the ligaments, are we truly treating the whole patient? Ignoring the emotional tolls akin to addressing only half of their suffering. In our pursuit of holistic care, that's simply not good enough. Fostering a positive mental state, providing psychological support where needed, and acknowledging the emotional burden are crucial not only for enhancing a patient's ability to cope with pain, but also for encouraging them to actively participate in their rehabilitation and regain their confidence and independence.
That's a powerful reminder of the holistic approach required and the profound impact beyond the physical joint itself. Building on that, what proactive measures can individuals take, and what long-term strategies can we empower our patients with to effectively manage this condition, both before and after any potential intervention, ensuring their overall well-being?
Empowering patients with proactive strategies for prevention, where possible, and certainly for long-term management, is absolutely crucial for their sustained well-being and functional independence. This isn't just about treating the joint when it becomes painful. It's about equipping them for a lifetime of joint health awareness. A primary recommendation is to adopt a proactive approach, starting with activity modification even before symptoms become severe, if possible. This includes being mindful of and consistently avoiding or adapting activities that place excessive, repetitive strain or cause pain in the thumb joint. Listen to your body. Regular physical activity, particularly specific exercises that strengthen the muscles surrounding the CMC joint, like the thenar muscles, and improve pain-free range of motion, is essential. This isn't about working through sharp pain, but building robust dynamic support around the joint to potentially stabilize it and offload the stressed cartilage.
Strengthening the supporting muscles.
Yes, dynamic stability is key. Ergonomic adjustments are another really important area. We strongly advise patients on the judicious use of assistive devices and ergonomic tools. Simple items like specialized jar openers, key turners, ergonomic pens with wider grips, or even large-handled utensils can significantly alleviate stress on the joint during daily tasks. Education on joint protection techniques and proper hand positioning is vital for maintaining functionality while minimizing pain. For example, instead of using a tight pinch grip with just the thumb and index finger to lift something, we encourage patients to use the whole hand or both hands to grasp, distributing forces more broadly across stronger joints.
Smart techniques to reduce the load.
Precisely. For individuals experiencing early symptoms, early intervention strategies are highly effective and can potentially alter the disease trajectory or at least manage symptoms effectively for longer. Prompt conservative treatments, such as custom-made splints for support during activities, and judicious use of analgesic and anti-inflammatory medications, oral or topical, to manage pain and inflammation can make a significant difference. Early engagement in manual therapy with a hand therapist and the consistent use of therapeutic taping, like kinesiotape, can also contribute to joint stability and provide pain relief, potentially delaying or even preventing the need for surgical intervention for years in some individuals.
So acting early with conservative measures is beneficial.
Definitely. Finally, we need to empower patients with comprehensive long-term management strategies that go beyond just the physical. This includes ongoing education about lifestyle modifications, such as maintaining a healthy weight to reduce overall systemic inflammation and joint stress, and advising on workplace ergonomics tailored to their specific roles. Crucially, it involves fostering self-management techniques and developing effective coping strategies for dealing with chronic pain flares when they occur. This could mean incorporating stress reduction techniques like mindfulness, meditation, or Tai Chi. Practicing deep breathing exercises can help manage acute pain episodes. Seeking support from counseling services or arthritis-specific support groups, like those run by Basal Arthritis, can be invaluable, allowing patients to connect with others facing similar challenges and share coping strategies.
Focusing on the whole person again.
Absolutely. What's truly fascinating and powerful here is the positive impact of encouraging patients to focus on enjoyable aspects of life, maintaining strong social connections, and continuing to engage in hobbies and activities that bring them joy, even if those activities need to be adapted slightly. These elements, while seemingly separate from orthopedics, are fundamental to enhancing overall quality of life, reducing the perceived burden of the condition, and allowing patients to thrive despite living with chronic pain.
This has been an incredibly insightful deep dive into basal thumb arthritis, covering everything from the intricate anatomy and pathophysiology right through the diverse range of conservative and surgical treatments, and critically, finishing on that holistic journey of recovery and well-being for our patients. As we consider the significant forces at play in such a small but vital joint, it truly underscores the remarkable resilience of the human hand and perhaps the often underestimated mental fortitude required to navigate chronic conditions like basal thumb arthritis. It leaves me wondering, what more could we as medical professionals perhaps do to better support our patients, not just surgically or pharmacologically, but truly holistically in their long-term journey with chronic conditions like this?
That is a profound question, and it really speaks to the evolving nature of medicine, doesn't it? Perhaps our greatest future challenge, and indeed opportunity, is not just to fix the specific anatomical part, but to truly care for the whole person, integrating all aspects of their physical, emotional, and social well-being into every single treatment plan we devise.
Thank you for such an enlightening discussion today. If you found this deep dive valuable, please do consider rating and sharing this with your colleagues. It really helps us reach more professionals. Thank you for tuning in to The Deep Dive.